If the previous presentation was really trying to invent the wheel again, in this invention we are trying to take the same things that we are doing today, treating patients with contact lens and drops, and just to make it a little bit better, while not changing how we used to practice and to treat. So previous presentation was on the EndoArt. Now we're going to speak on the HyperCL. The HyperCL is a soft contact lens with special design to give its function. The function of the contact lens is that it's built in such a way that every drop that we are going to apply on the surface of the contact lens will be entrapped by the small holes into a groove and a special design base curve that will create a reservoir above the cornea. So this is after instilling a high molecule fluorescein. High molecule fluorescein is not the same fluorescein that we are using in the clinic. It's a fluorescein that will not stain the matrix of the lens itself, and actually the lens continue until 15 millimeter, and you see it's not stained at all. You can see the reservoir over the cornea and the groove which entrapped any material, any medication that we would like to use. This is an inferior view of a model that we've built. The lens is sitting on an artificial cornea, and we are photographing from below, and there is a mechanical blinking, and you can see how the fluid, with high molecule fluorescein, is maintained in the center, and after each blink it goes a little bit to the periphery and then goes back again to the center. This is already on a patient. You can see the hydrostatic level of the fluorescein above the cornea. And this is another contact lens that we created with holes, just not built in the right way, and it does not entrap and does not create any reservoir. So today we have already an FDA and a CE, and in Europe, and I think the AMAR is shortly to follow. It is for a prolonged use for 1 week.
1 week?
1 week.
Because the first time you say only 1 week.
Yeah, exactly. But
it's not comfortable for the patient with problem in the surface of the eye to remove every day the
correct. So now it's approved for 1 week.
Yes, in Europe and in Israel and in Canada probably soon. In USA it is approved only for 1 day. We all know that regulation is regulation, and the process that we have to go through. So looking at a lens like this, we thought that many indications that might be good for using this lens. We have a lot of research going on, and the first results we got from corneal edema, which I'm going to present now, relatively briefly, because tomorrow we're going to see some in-depth examples of patients from Poland. We have Dr. Eva here, and she will show you some very nice OCTs from patients that were treated due to corneal edema with this lens. Other things that we are searching now is collagen cross-linking, uveitis, of course infection and inflammation may be the main indication for this lens, because you need it only for the bullous short term of treating infection and maybe for anterior uveitis. We are waiting to see the results that we are going to get there.
So now, in normal glaucoma or in
sorry?
In normal glaucoma?
So glaucoma is something that we did not intentionally started to investigate. Actually, companies came to us and showed us better results with our lens. As a doctor, I don't see how a patient with glaucoma will put also a lens, but of course we are supporting, and it's interesting for us also as a proof of concept of penetration of a material into the eye, and I'm always ready to change my mind if somebody will enlighten me with new results. Mm-hmm. But they get decrease intraocular pressure, so a higher delta of IOP change when using our lens. How it's going to translate into real practice, I don't know. So now I'm going to show you a multi-center study that was made in 4 centers, 2 here and 2 in Poland, that actually follow up the lens. I will skip this. This is not for doctors. We had two groups. Group A used our lens for 1 week with salt water and antibiotics for 7 days, and Group B used regular soft contact lens Bausch & Lomb with salt solution and antibiotics. So the same treatment, just different lens, and same patient went into A or B group in a randomization and had a 1 week of washout between the groups. So the results that we got, the whole group had, while using the hyper-CL, has improved in 1.4 ETDRS lines as compared to 0.5. And when we compare 3 lines of ETDRS improvement, there was almost 30% of the patient has improved in 3 lines as compared to 11.5. And the corneal thickness in the whole group has improved in or decreased in 41 micron as compared to no change with the normal contact lens. The inclusion-exclusion criteria of this study was very permissive. Actually, we did not excluded comorbid, such as other reasons of that can impair the visual improvement, such as any other comorbid in the eye. And we decided to make a cutoff of a patient that had a finger count and better vision. We assumed that those patients had better visual improvement potential because we saw that some of the patient has decrease in thickness of the cornea but no visual improvement because of other eye illnesses. So in this group we had 18 patients. 44% of these patients has improved in 3 lines compared to 12% while doing the normal, using the normal contact lens. When we try to make more, let's speak about adverse event. When we compare the 2 lenses, both groups had the same adverse events, such as discomfort, small erosion from time to time. It depends also on the amount of corneal edema that the patient has. We know that this is maybe part of the illness itself, of the disease itself. There was no serious adverse event in any of the group, and actually there was no real differences between using normal contact lens and our lens. When we try to maximize our result, I can conclude that I recommend this lens for patients primarily in their better eye, have finger count and above, and has a corneal thickness of 640 microns and more. In this patient, we get 44% of 3 lines of improvement, and we know how dramatic it is. Why do I say in the better eye? Because if someone sees 12, and the other eye, which is the edematic house, is a finger count, and then he get 660 in this eye, he still used the better eye, and he just complained about the comfort. So to get motivation for the patient, if someone wants to try to practice this, I will recommend him to start to treat the better eye, which is suffering from corneal edema. Of course, for the 2 presentations, I just want to thank all our group, which I have an excellent group, and this is our scientific advisory board, and back maybe some of the people here are more recognized than the other, and thank you very much.
Okay.